Hey guys, guess what? We made it. This is the fifth and final module for this summer session. I hope that you've learned something about the OT profession and you're going to be able to share that with me in the discussion. So, this module is going to consist of talking about the OT process, which we're going to talk about in this presentation. Then we're going to talk about models of practice, modalities, and treatment settings. The last presentation in this module will be information about your case study, and then there'll also be a discussion thread and an examination. You are almost there. So let's get started. So what is the OT process? This is actually in your OT practice framework book. So if you want to pull that out and look at it and follow through, that would be great. But basically, the OT process, starts when we initially get the referral. This is a referral for us to see somebody for therapy. We receive this referral, which we're going to talk about how we get that in a little bit later. But we receive the referral, then we gather all the information. This is part of that occupational profile. We're gathering information about our client. We're gathering information about why they're there. Then as we are doing the evaluation, we're looking at all those concepts in the OT practice framework, and we're pulling it all together. That's all part of the interview as well. Then after we complete the assessment, which this is a little bit different here, we're going to set some goals and work on an intervention plan and a discharge plan. We're going to talk about these steps much more in detail. So OT has a unique perspective. You might have heard of physical therapy or speech therapy, and they have a similar process that they incorporate for evaluating providing intervention and targeting outcomes for individuals. But only OTs consider and really focus on that use of occupations. And we do this in order to promote health, well-being, and participation in an individual's life. We use theories and knowledge. We use skills and evidence-based practice to guide what we do. We analyze all the information that we receive from multiple complexities, and we really attend to each one of these, but then prioritize to determine what is the most important in the care of our client. The process doesn't necessarily follow a linear or sequential manner, but instead it's dynamic and it's ever evolving. So as the client changes or as the context change, we have to change what we do. Think back even about therapeutic use of self and how we build those relationships. They too are very dynamic and it can change over time, and it's not a linear process. And as we're going to talk about, a client can be considered an individual or a group or a population. This is all outlined more in the OT practice framework, so please be sure to look at that. Okay, so on page S17, you're going to see a table that looks similar to this. And as you see in the pink, it talks about the evaluation. And this looks at the occupational profile. The occupational profile and the analysis of the occupational performance. So what is the individual actually able to do? Okay, so we're assessing we're looking at all the client factors, we're looking at the performance skills, the performance patterns. We want to see how their deficits are impacting their occupational performance, how their ADLs are being affected. Then we're going to create or look at the intervention. This is the yellow section in this slide. This looks at creating an intervention plan. This is kind of like a roadmap. We're going to talk more about this in a minute. We're going to identify and create an intervention implementation. And then we're going to review that intervention to make sure that it's working as we expected or as we want it to. And then we're going to be looking at targeting outcomes, which a lot of times people will think of as the discharge from therapy, but there's actually many components that we look at when targeting outcomes. So when we look at this OT process, we really use many aspects of therapeutic use of self, such as advocating and collaborating, empathizing, encouraging, instructing, and problem solving. So we're looking at all of these aspects of therapeutic use of self throughout this process. So what is the OT process? To begin with, there needs to be a referral. Kind of talked about that a minute ago. But where does the referrals come from? So we can receive referrals through early intervention. So if we're working with children, early intervention is providing services to children from birth till 3 years of age. We receive those referrals often from a physician, or it could be a parent. It could be the county representatives. It could be another provider that's working with the child that recommends that they need OT services if they're already receiving services. That's where our referrals come from. When we're in a school setting, the referrals likely come from a teacher or a psychologist, or maybe even another discipline. Again, if the child is receiving maybe speech therapy or physical therapy, they may make that referral for OT as well. It could also come from a physician, but it tends to not be as prevalent in a school setting. It tends to come from a school personnel or school staff person. Then when we're in a hospital or a skilled nursing facility, much like a rehab center, the referrals usually come from a physician. They can be made from other areas or other professionals in the settings, but generally they will come from the physician. If a nurse or a social worker or other healthcare professional like PT or speech therapist think a person needs OT, they can make that recommendation to the physician, but the physician ultimately will make the referral. When in home care, it could actually be a spouse or a caregiver of somebody that's working at home with the individual and identifies that they're not able to do what they were doing previously. Could also come from a physician as well. If they may have fallen, or the caregiver or the patient went to the doctor and said they're not able to do something at home, the physician may make the referral. And then in the area of wellness, this is a little different. So this could actually be in a variety of settings. When we're looking at health and wellness, this is looking more at a group or a population versus an individual. And you're looking at something more holistically. So if you're combating homelessness, okay, and you want to work with the homeless population, this can come about in terms of the referral from another agency or another professional that's working within the setting that decides that somebody needs to, an OT can help out with some aspects of improving homelessness. That's just one example. One of the things that I hadn't talked about was psychology or psychiatry. So if you're going to work with mental health individuals or individuals within a mental health arena, if they're in a hospital or at a psychiatric center, you again will be receiving those referrals from the physician or the psychiatrist. If you're doing it more as an outpatient, like a clubhouse setting, then that would be more on the wellness side of it. And the referrals would be made usually from the person within those houses. Now, in order to provide OT services, we have to have a prescription. We are licensed, our license falls under the medical model, which requires that we have a prescription in order to provide treatment. So this is done in a school setting, this is done in a home care, this is done in a hospital or nursing home or psychiatric center. Any of these areas, we need to have a prescription from a physician. Okay. So the first part of what we do during the OT process is sometimes is a screening process. So what happens is what we do is we receive the referral and we take preliminary data and gather that information in order to determine if an additional or thorough evaluation is needed. So often you'll see this in a school setting. Or the school teacher may come to you in the child's in kindergarten, and they may say, you know what, we're having a hard time with a child with handwriting skills. Could you come in and just make some recommendations? We would make those recommendations prior to doing a complete evaluation. In a hospital setting, I know that when I worked at an area hospital in Syracuse, anybody who had had a stroke and was admitted to the hospital, the rehab team, so we would have a speech therapist, an OT, and a PT would go together, and we would do a screening to see if the individual was appropriate for an occupational, physical, or speech therapy evaluation. So basically what you're doing is gathering that preliminary data and then determining if another evaluation or a full evaluation is necessary. So just kind of came through this. So you had the reason for referral. You're going to do an observation and a short interview with the client, including that brief occupational profile. What is important to them? How are they doing? Are they having difficulties with anything? That's kind of what we're looking at. Assessment and results if needed, but generally that's not done too much in the screening process, but of course you can make recommendations. So here's just a picture of Ella. So Ella is actually a child who is in second grade. And if you look at the way, I'm sorry, she's first grade, getting ready to go to second grade. But as you can see, her letters are all over the place. What was written in red was by her teacher, and then she wrote in pencil down below. If you notice, her E has extra lines in it. Her first L is very high on the paper, the other L is upside down, and the A is kind of floating off on its own, but it almost looks like an H. This is not what would be expected for a child going into second grade. So looking at this, part of my screening would be seeing what they've done in the classroom setting already, how has she improved, and if she's not making progress or if they've tried many things and progress hasn't been made, then a referral would not be necessary. That's just an example I'd like to share with you. Okay, so now we're looking at the occupational profile. This is gathering information on the client, the who, the what, the why, the where, what can be done, what are the priorities of the client, what's their occupational history. We've kind of talked about this. This is where we're going to bring in that therapeutic use of self and try to get information from the client so that we can create a holistic setting for this individual to share their information with us. Then we're going to go to the analysis of the occupational profile. So now that so now after learning what the client's occupational performance is, the OT is now going to determine what are the client factors, performance skills, performance factors, context, and activity demands that the individual needs to engage in and what areas of they having difficulty in. Now, looking back at the occupational profile, this is something that could be done by an OT assistant. Remember, we talked about this earlier in this semester. But when we get to the analysis of that occupational performance, this is only something that an OT can do. This is why we are what we are. You know, we are looking more in depth. We want to see how an individual is functioning. So now after analyzing what we identified, we've often, for the analysis of the occupational performance, we may have administered standardized testing. We may have observed the client completing an activity to see what they're able to do and what difficulties they're having. We may have had them write something down. So there's a variety of instruments that we can use in order to analyze their occupational performance. Once we've done that, now we're going to develop a plan. So this is what we call an intervention plan. We develop this plan based on different theories and frames of reference and evidence-based research. We're going to talk about that much more in the next slide presentation. But anyway, we take that, what we've learned about the client, what are those clients' priorities, and now we create a plan for them to work towards, and we're going to work with them on, and we're going to develop goals for that individual. Now, in order to determine the goals, we have to identify how they're going to reach the highest level of independence or highest level of function that they can do. We may have to look at rehabilitating a lost function. So for an example of this is somebody who has had a stroke and they've lost the use of the right side of the body, or we'll say the right arm. We're going to have to create a goal that incorporates rehabilitation. When we look at adaptive equipment, this is if somebody is not able to complete tasks because of some physical impairment that has gotten in the way, maybe temporary or maybe long term. We might have to provide them adaptive equipment in order to complete whatever tasks they need to do and to be as independent as possible. Let's think back of the scenario of an individual that had a total hip replacement. They're not able to perform lower body dressing because of those hip precautions without the use of adaptive equipment. Therefore, the goals for that individual would be implementing adaptive equipment in order to care for their own needs. The next level is home modifications. This is done for an individual that is going to need modifications in their home in order to be independent when they end up going there. This could be somebody, again, with a total hip replacement, what needs to be done in their home environment in order for them to be safe. Or maybe it's somebody that has more of a chronic condition now. Maybe this is an individual that had a spinal cord injury. They were ambulatory or walking prior to their injury, and now they're going to be in a wheelchair. What modifications are going to be necessary in order for them to live independently? And then the last one is client and caregiver guidance. Also think of this as an education. How do we need to educate our clients and educate our caregivers of the clients in order for them to make sure that that client can be as independent as possible and safe while living in the area that they're going to be living in? So these are generally the 4 types of goals that we're talking about. These are also listed in the ODPF. When we talk about treatment planning, we have to identify what the problem is, and then we have to develop goals in order for the client to achieve them. So I have an example of one here. So we talked about Ella. So one of the long-term goals, because of course going into 2nd grade, she should be able to write her name pretty accurately. She wasn't able to in that example that we had. So my long-term goal is that Ella will write her name with uppercase letters within 2-inch lines with 75% accuracy. Makes sense. Her short-term goal, these are stepping stones that are used in order to get to that long-term goal. Ella will improve visual perceptual skills to identify uppercase letters in her name, 8 of 10 trials. Ella will increase the functional grasp to maintain a functional grasp on writing utensils with modified supplies is needed for 80% of trials. And then Ella will also increase sensory regulation to attend to a seated writing task for up to 2 minutes following sensory input with no more than 3 verbal cues. Looking at the case example of her writing her name, you might not have been able to get all of this information from Ella, but I actually worked with Ella. So these are the goals that we developed because when looking at her occupational performance, Ella had a hard time sitting still. She had very poor grasp patterns, and she also had visual perceptual difficulties. So that's why we're creating these goals. I don't want you to sweat too much over goal writing. This is obviously your first chance or first opportunity looking at something like this. You're not going to be graded on this, but there will be some components in the exam that talks about different parts of goals. So we're going to get to that now. Actually, we're going to get to that in a minute. Okay, so now when we talk about the intervention, this is looking at, there's 5 different areas that we look at when we're creating the intervention. Are we creating and promoting something? Are we establishing and restoring? Are we maintaining? Are we modifying? Or are we preventing? Okay, so a couple of minutes ago we talked about how to create a goal, but now this is how to look at the implementation of an intervention. We're going to talk about these much more in detail. All of this information is in the OT practice framework, so please look at this to gain more insight or gain more understanding of each one of these, as I'll be going through them pretty quickly, but you're going to want to know these for the exam. Okay, so when you're creating and promoting, this is creating and promoting something new or something that is like an alternative to something that somebody was not able to do anymore. So here's some examples. Creating a parenting class for first-time parents to engage their children in developmentally appropriate play, or provide a falls prevention class to a group of older adults at a local senior center in order to encourage safe mobility throughout their home. So as you see, the create and promote are actually, these are two different types of goals that we would do. The first is really for individuals that are very new to parenting, and then also very new to parenting a developmentally challenging child. They could also be included in this group. The second example is looking at seniors. And we know there's a lot of evidence to show that as people age, they have a higher prevalence of falling. So we want to make sure that we can keep somebody safe as long as possible. And so incorporating a falls prevention class can do that. The next one is establish and restore. So now this is looking at improving function once something has been lost, or developing something that somebody didn't previously have. A couple of examples is restore a client's upper extremity movement to enable transfers of dishes from the dishwasher to the upper kitchen cabinets. Okay. A second example is develop a structured schedule, chunking tasks to decrease the risk of being overwhelmed when faced with many responsibilities of daily roles. And the third one is to collaborate with a client to help establish morning routines needed to arrive at school on time. Again, you can see how we're creating something in order for somebody to be successful. Maybe we're chunking or breaking down the tasks so that they can be successful. Or else maybe we're going to create a list of steps for them to follow in order to get a final outcome. So as you can see, these are what we're talking about for establish and restore. The next one is maintain. So this is, when we think of maintain, this isn't something that generally comes to mind when we're talking about therapy. But there are individuals that we work with that maintaining is all we're going to get. So the first example talks about amyotrophic lateral sclerosis. This is a diagnosis of an individual that is not going to get better. It is progressive and it is eventually debilitating, so that they're not able to care for their own selves. But what we can do is, one of the examples is provide ongoing intervention for a client with ALS to address participation in desired occupations through the provision of assistive technology. So we're going to provide assistive technology alternatives in order for them to maintain the highest level of independence that they can. The next example is maintain independent gardening for people with arthritis by recommending tools with modified grips, long-handled seating alternatives, or raised gardens. Again, somebody that has arthritis, it's most likely not going to get better, but they want to continue to do gardening. So how are we going to keep them as independent as possible? So we're going to do that by providing alternative tools and alternative seating positions and different gardening styles. The next is maintain safe and independent access for people with low vision by increasing hallway lighting in their home. Again, we're not going to change somebody with low vision, but what we can do is we can increase the lighting or improve their safety within their house. So that's what we talk about with maintain. Okay, the next one is modify. This is where we simplify a task sequence to help a person with cognitive impairments complete a morning self-care routine. We can consult with builders to design homes that will allow families to provide living spaces for aging parents. And we could modify the clutter of a room to decrease the client's distractibility. In OT, we tend to modify a lot. This is one of the things we're really good at. When you can't complete something the way it's done, we're going to make some alternatives. We're going to modify the tasks, modify the environment, modify the tools that the individual can use in order to get the job done. The next one is prevent. Obviously, there's times where you want to just prevent further injury. You want to prevent social isolation. You want to prevent injury. So this is where this comes into play. There are OTs that work with big businesses, in order to make sure that their workers stay safe. It's called ergonomics. So they're designing different programs, different working environments. They're doing training in order to keep a person safe on the job. So this is what we're talking about in the area of prevention. Okay. So how is OT provided and who provides it? So as we mentioned, you can do it in a client, a group, or an individual, a group, or population. And we can also do this by direct training, by working with the family, and this actually is CAR, but I think it's supposed to be caregivers, so I apologize for that. But you're working with the caregivers. In terms of indirect, we're looking at consultation. So this can be done in a variety of ways. This can be done not person to person or person to person. It can be done through telehealth. It can be done by talking to a classroom teacher, and then they're making adjustments for the entire class. So there's lots of ways that we can do it indirect. Adapting materials and adapting tools. Again, that's not necessarily a direct intervention. Suggesting and modifications or accommodations can be done in a group setting. It doesn't have to be for an individual. If you think about individuals who have arthritis, working with individuals in a group environment and sharing what modifications or accommodations are out there can be very helpful through an indirect mode. Explaining challenges or concerns, again, to keep a person safe in their home. Just general information can be done on an indirect basis. Home programs, just general home programs that are not specifically targeting certain patients or certain movement patterns, but just general ways of improving your strength or general ways of conserving energy. These can be done on an indirect basis. And then developing programs can also be done on an indirect basis. Again, there's more information in your reading, so please be sure to do that. So we talk about the OT process. It's occupation-based. It's client and family-centered. There's collaboration with other health and medical professionals. We're always looking at functional outcomes and measurable outcomes, and it is evidence-based. So now we have to identify, is the intervention working? So as you're working with a client, you're going to come to a time you have the goals set out. You're going to reassess their goals in a certain time frame, and you're going to want to know how well they're progressing towards those goals and if those goals have been met. If they have not been met, do they need to be revised? Do you need to make some alterations in that goal in order for that person to be successful? If in fact they did meet those goals, it's time then to add another goal. If they're not totally independent, but they're not where they were when they started, we may have to make another goal for that. Is there a change in context or environment? And therefore, are those goals needing to be revised? So these are all reasons why we might do a reassessment. Then we look at the targeting outcomes or the discharge process. Are the goals met? Is it time for graduation? And is a person safe to be discharged home? Whenever we complete any area of the OT process, we have to look at documentation guidelines. We have to document everything that is done. If we don't document, then it wasn't completed. Just remember that statement. If you don't document it, it wasn't done. We document to identify the evaluation. We document the interventions. We document the goals. We document the targeted outcomes. How is a person progressing? We document the discharge plan. All of this has to be completed in order for us to get paid. Documentation complies with various types of regulation, insurance companies, site-specific terminology or site-specific requirements. Like if you're in a hospital setting, there might be some terminology that you're expected to use or abbreviations you're expected to use. If you're in a school-based setting, again, there's going to be site-specific terminology or abbreviations. We always have to follow the laws and the regulations of the regulations of any of the accrediting bodies, and then the laws of the state, whatever they say you have to do. Documentation can be done through a handwritten format or electronic, and we always have to have a signature. Whenever you complete a signature as a healthcare professional, you have to write your credentials. If you make an error in any of your documentation, you're going to write a single line through it and then initial it. It always has to be readable. Even if it's an error, it's a legal document. So we have to make sure that we don't scribble anything out. You just draw one line through it and then put your initials there. Okay. We're getting to the end here. I know, guys, it's kind of long. This is going to be the longest one of this module, but it was kind of hard for me to break it up. But I want to talk a little bit about modalities. So when we talk about preparatory methods, these are activities, exercises, sensory input, physical agent modalities, or orthotics that we use to help a person get to an occupational-based activity. So you might find that somebody's going to do arm exercises, or in order to increase their strength so that they're able to comb their hair, or they're able to braid their hair, or they're able to get dressed. You might find that an individual that had a total hip replacement, you're going to teach them arm exercises so that they can use a walker safely so that they can get from one place to another. Those are preparatory methods. You might be working with a young child that can't sit still in their classroom, and they need some physical input in order for them to be able to organize their body and sit still. That is also a preparatory method. So these are activities that we use in order for us to get an occupation-based result. When we talk about physical agent modalities, we're not going to sweat and talk a lot about that now, but you've probably all used heat or ice. That's kind of what we're talking about. So if you have sore muscles, in order for, so say you're mowing the lawn and you found that you kind of just have some sore muscles, you might decide to put ice on your muscles for a little bit prior to finishing up the lawn mowing activity. That would be the physical agent modality. When we talk about orthotics, this is anything that would be used for like a splint or I'm trying to think of it, like a splinting. So if you've ever had a splinting, or you've ever had to wear a brace because maybe you sprained an ankle, or maybe you've jammed a finger, anything like that, and you've had something on there to help support that joint, that would be considered an orthotic. And that's also a preparatory method. You're using that in order to stabilize a body part so that you can complete an activity or a task. When we talk about purposeful activities, they can be simulated or contrived, occupation-based activities. We can do this through consultation, education. We've already talked about the activity analysis and the activity synthesis. So this information we've kind of already talked about before, but I want you to understand that it falls under purposeful activities. Okay, we're at the end. So there are 3 examples here, and I'm going to have you look at these on your own. They last anywhere from 1 to about 3.5 minutes. The first video is an occupational therapy evaluation of a person who's had a total hip replacement. The second one is looking at OT arm exercises, and this will be by an occupational therapist. And then the last part is OT discharge. The first one, what I'm going to do is after you complete the video, I'm going to ask you to explain what types of therapeutic use of self you saw throughout the evaluation. When looking at the OT arm exercises, I want you to explain to me what types of preparatory activities or preparatory methods that OT was using. And then when you're looking at the OT discharge, this is looking at the difference between the OT and a PT in terms of a profession. It's a cartoon-based video. It's very cute. And with this one, I'm going to have you identify what is the unique perspective that OTs bring to a situation at times of discharge. All right, guys, that's it. And good luck, and I'll talk to you later.